Assalamu alaikum everyone. Welcome to DentoScope Studio, the official YouTube channel of DentoScope Institute of Advanced Dentistry. Uh, we have started a new series of live lectures by DentoScope mentors, and today I am joined by Dr. Namrah Bashir, who is the Managing Director of DentoScope Institute of Advanced Dentistry. She is M-Phill in Oral Pathology, and she is going to brief us about the cyst of oral cavity. Over to you, Dr. Namrah.
Thank you, sir. Assalamu alaikum, everybody. I am Dr. Namrah Bashir, and I'm going to talk about cysts of the oral cavity today with you all. And it is going to be a very brief lecture. We are not going to cover all the cysts, as there are a lot of cysts in the oral cavity, but we are going to cover all the important ones. So first things first, let's just look at the learning objectives that basically our goal at the end of this lecture. The goals would be that at the end we would be able to define what is a cyst. We would be able to classify cysts of jaws in different ways, and at the end of this lecture we would be able to elaborate clinical, histological, and radiological features of different types of cysts of jaws. And lastly, we would be able to briefly explain and touch different management of the cysts, and we won't go into the detail of those management, as that would not be in the scope of this particular lecture, but we will touch management as well. So what is a cyst? Here I have a very simple definition of a cyst, and it's by Kramer, given in 1974. I'm just going to read it out. A pathological cavity having fluid, semi-fluid, or gaseous contents, and which is not created by the accumulation of pus. Now, most of the cysts are lined by the epithelium, and most of the pathologists call a cyst only if it has a epithelium. If it lacks an epithelium, we would not call it a cyst. We would call it a pseudocyst. So one thing to remember is this basic diagram right in front of you, where you can see that it is lined by a epithelium. There is a fibrous capsule outside this epithelium, and at the center we can see a lumen cavity, which may be filled with the fluid, which may not be filled with the fluid. So this is a basic diagram of a cyst. In order to diagnose a cyst, we need to know certain pointers so that we can reach a particular diagnosis. A cyst would always be well defined. It may have scallop margins in cases of certain cysts like odontogenic keratosis, but most of the times it would be well defined. It would be radiolucent. Why radiolucent? Because obviously it is an empty structure, as we have discussed earlier. It would appear radiolucent in the radiographs. Then we have this very important point here: slow growth. A cyst basically grows very slowly. It is a benign lesion. Most of the benign lesion do not grow slowly, but it has this very slow growth, and because of this, it may go unchecked. And most of the times, we will diagnose a cyst when, in a very accidental way, under a radiograph. Related to the slow growth pattern, we have an expansile. Expansile is another feature of a cyst, in which it basically expands slowly, and because of this expansion, it affects different structures surrounding it. Yeah. Then I've talked about asymptomatic before as well. And lastly, the most important thing is that we cannot identify a cyst just on the basis of clinical history. It's very important that we have the radiographs, and it's also very important that along with those radiographs, we have the histological diagnosis of a cyst. Only then we can reach to a diagnosis of a cyst. Now, earlier I said that when cysts grow in size, they affect the adjacent structures. Now, these adjacent structures could be nerves, they could be bone, they could be a tooth. Depending on the structure, we may or we may not get the symptoms. If the nerve is present around the cyst, it would give a person would complain about paresthesias, about numbness, especially if the cyst is present near the inferior alveolar nerve. If it is a dentigerous cyst, which is often associated with third molar, then our patient, he would have numbness in that area. He would experience paresthesias in those areas. Then here in this picture, you can see how two roots, they are just going away from each other. So this is very common. This is common in buccal bifurcation cysts. Then if a cyst is growing in size, we can see the bony structures around it expanding. We can see different tooths that are different teeth that are getting displaced because of the expansion of that cyst. So pathogenesis. Why is the cyst formed? Cysts are basically, they can be developmental, they can be inflammatory. But the cells which are responsible for the growth of those cysts are cells rests of molasses, reduced enamel epithelium, and cell rest of series. Now, there are different types of cells involved in different types of cysts. We are not going to go in the detail of those cells, but what we need to know here is that when these cells, they proliferate, they grow, they cause an expansion in the cystic cavity. As a result of that expansion, a pressure is created. That pressure causes the size of that cyst to grow and the surrounding bone to resorb, and we get a cyst. This is the very basic mechanism. The stages of this mechanism are important, and we will talk about them in the later slides. The first stage is initiation, then we have cyst formation, and then we have growth and enlargement. Let's talk about initiation of a cyst. Initiation, it's very easy to remember. Inflammation of a cyst. When inflammation of a particular area, inflammation occurs when there are different cells at that area and an inflammatory process starts. It could be because of any trauma, it could be because of a tooth which is non-vital, it could be because of bacterial toxins, immunoglobulins, cytokines, it could be T lymphocytes. Once the inflammation is started, the cyst will start to form. After the inflammation and inflammatory cells, we will see proteolytic enzymes. They will come into that area and cause the degeneration and death of certain cells in that area. And as a result, we will see formation of cavity in those areas. Initially, they would be very small microcystic cavities, which will later on coalesce together to form a large cavity, which will be later known as a cyst. And the surrounding epithelium, we will see it getting proliferated and thinning out and forming a very thin lining of an epithelium. Depending on the cyst, it could be 2 to 3 mm thick, it could be 4 to 5 cells thick. It all depends on what kind of cyst are we talking about. Lastly, the cyst enlargement. We have a theory over here that why do cysts enlarge? So the theory here is, I'm going to discuss very briefly hydrostatic pressure theory, in which basically as the cyst size increases, the osmotic pressure, it also increases. Now, remembering the chemistry lectures, as the osmotic pressure increases, the permeable membrane surrounding that cyst, it allows the water and the fluids to come inside that cavity. And as those water molecules, they come inside the cavity grows and the cyst enlarges. It's very simple. The diagram here, you can see how this epithelium is getting expanded. The surrounding fluid, it will move into the cystic structure, and as a result, we will see a large cystic cavity. Okay, this is important basic classification of a cyst, as we have earlier talked about pseudocysts and epithelial cysts. Some of the cysts are surrounded by epithelium, some are not. The ones that are not surrounded by an epithelium, we call them non-epithelial cysts, and the ones that are surrounded by an epithelium, we call them epithelial cysts. Among the epithelial cysts, we have odontogenic, which are related to the bone, and non-odontogenic, which are not related to the bone, which are mostly around the gingiva or soft tissues. And among the odontogenic, we have developmental and inflammatory. These are the names of various odontogenic and developmental cysts, odontogenic inflammatory cysts. You don't need to remember the names of every cyst, but we are going to discuss the important ones so you'll know which ones are really important and the ones that are common in clinical practice. These are the 3 non-odontogenic cysts: nasopalatine, nasolabial, non-epithelial line pseudocyst, which consists of solitary bone cyst and aneurysmal bone cyst. Then we have soft tissue cysts. We are not going to discuss soft tissue cysts in this lecture, but I just mentioned it so that you would know that there are certain kinds of soft tissue cysts as well. You can see this diagram here. You would understand it once you know every cyst, but a general idea is that odontogenic keratosis, how it appears as a multiple cyst. There are multiple, we see the multiple cysts in the whole bony area, which later on, after radiographs and after proper histological diagnosis, we'll come to know that it is an OKC. Here we see a radicular cyst, which is associated with the periapical surface of a tooth. This is a residual cyst, which is formed after the extraction of the cyst, after the extraction of the tooth. Then we have dentigerous cyst, which is often related to the third molar. We have eruption cyst, which is seen in those in erupting submerged teeth. It could be in a newborn. They could be seen in a, mostly they are seen in a newborn or younger kids who have developing tooth, who have erupting tooth in their mouth. Then we have calcifying odontogenic cyst, another important cyst. It has these calcifications inside it. We'll discuss it later on. Then we have an adult gingival cyst, which is completely seen in the gingiva. It could be basically adult gingival cyst is an alternative of a lateral periodontal cyst. We'll discuss all these cysts later on. Let's go into our next slide. How to diagnose a cyst. In order to diagnose a cyst, it is very important that we take the history of our patient. Detailed past and present history is very important. Apart from history, oral examination. This oral examination includes where the cyst is present, the site, inspecting it, palpating it, percussing it. We would check the vitality of the teeth which are involved with these cysts. And if it is important, then we may take the biopsies of those cysts and we may send it for the further investigation. Radiographs are again very important for the diagnosis of a cyst. Here I have mentioned this term eggshell crackling. Now, eggshell crackling is a term which you will see in oral examination of a cyst. As the cyst grows larger in size, the surrounding structure, the surrounding bone, it thins down. And when it thins down, and you tap on it or you percuss on it, you'll hear this eggshell crackling type of voice sound. So this is very typical of a cyst. So you need to remember this with the diagnosis of a cyst. Okay, let's start from the most common cyst, periapical cyst, also known as radicular cyst. Now, periapical cyst, it occurs most frequently in the mouth of different people of different ages. The cause is basically an infection. It is a chronic infection. So when we are talking about an infection, it means that the associated tooth, it would either be filled or it would either be endodontically treated. You can see in this diagram how this tooth is endodontically treated, how this tooth is filled. So this is a very important diagnostic marker. You can see if a tooth is vital, then we would not really think of a periapical cyst. But if it is non-vital, we would always and almost most of the times it would be periapical cyst. Then the pathogenesis of this cyst. Again, it is a developmental cyst. It is caused by cell rest of molasses. And as this cyst grows into larger cyst, it will appear at the apex of the involved tooth. Most of the times, the tooth which is involved may have caries. It may have, as we have said, that it may be endodontically treated. It may be filled. So these are all the diagnostic markers of such a cyst. Let's talk about its histological features. Histologically, you will see that the epithelium of this cyst will be stratified squamous epithelium. It may have a variable thickness. You can see here that it is, at some places it is thinned down, at some places it is thickened. Then there are very important structures in this cyst which are known as Rushton hyaline bodies. These are hyaline structures. You can see how the hyaline are basically these pink structures which are rounded and eccentric, and they appear this is a typical picture under the microscope. You would see it you would see it in these radicular cysts. These are very glassy appearing. And another important feature of radicular cyst is the presence of cholesterol clefts. Here you can see these are the cholesterol clefts in this diagram. Then we have lateral periodontal cyst. Now, lateral periodontal cyst is different from apical cyst on the basis of its site. It will always be present at the side of the tooth, at the lateral side of the tooth. And another important feature of lateral periodontal cyst is that the tooth which is concerned with this cyst are mostly vital. There might be exceptions, however, but most of the times these teeth will be vital. So that would be certain. That would be a very important difference between a lateral periodontal cyst and a periapical cyst. Here we can see a picture of a clinical picture of lateral periodontal cyst between 2.4 and 2.5. Certain you can see some mild expansion of the area. And later on, if you find now you won't be able to diagnose it right away by seeing it on the patient, by seeing it by examining it. You would have to go for a radiograph and you would have to go for a histological exam. Okay, now this lateral periodontal cyst also has a variant, and that variant is named as Botyroid variant. Botyroid means grape-like. You can see in the X-ray how this appears like small grapes which are coalesced together to form a large cavity. This is basically a variant of a lateral periodontal cyst, and this is how it will appear in the radiograph. Histologically, this cyst will have very thin down epithelium. An important structure would be seen in this epithelium would be largening of or thickening of this epithelium at certain places, and this thickening is often common in other cysts as well, but most of the time this thickening is seen in this cyst. Otherwise, the fibrous tissue, the connective tissue would be very loose. There won't be a lot of chronic inflammation because, again, as we earlier said, that this cyst is not related to infection. Inflammation is not present in lateral periodontal cysts. Therefore, in the histological features, you won't see a lot of inflammation. Then we have a residual cyst. Residual cyst is basically a cyst which is seen after an extraction is done. If a patient complains to you, or if you see it in a radiograph, you would see that there is no tooth present in that area, or in a recently extracted area, you would see the presence of this cyst. You might have to get it removed, or you might just keep a follow up and check if it disappears with time. Then we have dentigerous cyst, another important cyst of the oral cavity. Dentigerous cyst is again it is odontogenic and it is developmental. Now, dentigerous cyst is the cyst which involves the third molar, and this third molar is almost always unerupted. It could be fully unerupted, it could be partially unerupted, it could be submerged, and the cyst is always attached to the cemento-enamel junction of the tooth. Here you can see how this cyst is attached to the cemento-enamel junction of the tooth. And here you can see a radiograph which shows the third molar having the presence of this cyst with the third molar. Now, again, we're going to talk about these radiographs. How you can see how the presence of this cyst is seen with the third molar. Most often, if it is a third molar, if it is a cyst that involves the cemento-enamel junction that is connected with the cemento-enamel junction of the tooth, you would just get an X-ray, you would get the histological features, and you would just diagnose it as a dentigerous cyst. Another important thing about dentigerous cysts is three varieties, which are circumferential, lateral, and coronal. Just the diagram says it all. The circumferential covers the whole tooth, the lateral one covers the lateral surface of the tooth, and the coronal one covers the crown of the tooth. Histologically, there are two different pictures of dentigerous cyst. It could be inflamed and it could be non-inflamed. Most often it is non-inflamed, but in certain cases you may see an inflamed dentigerous cyst. It has a very thin epithelium. It is cuboidal epithelium 2 to 3 layered epithelium, and it is very much similar to reduced enamel epithelium. The underlying connective tissue is very loose. You may see chronic inflammation. You may see a very little to a large amount of chronic inflammatory cells in these in the features of dentigerous cyst. Okay, next is odontogenic keratocyst. It is a very interesting cyst because it is very aggressive and infiltrative features. As I mentioned here, it is aggressive, it is infiltrative, and it has a very high recurrence. 30% of these cysts have recurrence in these in patients in their formation. And here's a case of odontogenic keratosis where you can see a patient with a swelling on the right side. This is an intraoral picture. The X-ray shows a very large radiolucency, and this is the picture of a histological picture. We are going to talk about the histology, and over here, the characteristic feature of OKC is that the squamous epithelium is keratinized, and that is why we name it as odontogenic keratosis. That kerato comes from the keratinization of this epithelium. This pink area is basically keratinization. The basal cells basically shows very nicely placed picket fence tombstone appearance of hypochromatic basal cells. This picket fence or tombstone is named so because of its appearance under the microscope. And we will see that it is 5 to 8 cell layer thick. We will see that it has weak epithelial connective tissue interface. We will see some daughter satellite cysts. We will see thin collapsed and folded corrugated lining. Radiographically, it might be unilocular, it might be multilocular. And the extension in the medullary space is mostly from anterior to posterior direction. Then again, the keratocyst is treated by enucleation and marsupialization. We will discuss these later in our lecture. Now, another important thing about OKCR that in many of the patients, you will see a lot of multiple numbers of OKCs. Now, when that is present, you must always investigate for the nevoid basal cell carcinoma, because it's a very important feature of. Here we have nevoid basal cell carcinoma. You can see how a nevoid basal carcinoma has different features. A patient has other generalized features as well, but along with this, the patient has multiple odontogenic keratosis. So if you see a patient with a multiple keratosis in their jaws, you must always investigate for this carcinoma. Here are the two radiographs. You can see how the ramus of this patient is completely affected. There's a large radiolucency. Another thing to remember about OKC is that it almost always affects the ramus or angle of the mouth. Another X-ray shows multiple OKCs. They are present in both rami and they are multilocular. Okay, I added this diagram just to show you guys how OKC has been changed with how OKC has been classified over time. Initially, it was given the name of dental cyst and dermoid cyst, and as we go down in 2004, we see how it was classified as keratinized cystogenic autointogenic tumor. This was because of its infiltrative and aggressive features. But later on, because these aggressive features are not that convincing, later on in 2017, which is the most recent classification of OKC, it has again been classified into odontogenic keratosis. So this is very important to remember. You have to know that it is a cyst and it is not a tumor, but earlier it was considered as a tumor. Okay, then another important cyst is eruption cyst. Eruption cyst is basically seen in small kids, in children who have erupting tooth. Here the tooth, it basically breaks through the bone, but it fails to break through the gingiva, and that is where the cyst is formed. And you can see this bluish discoloration. This bluish discoloration is because of the blood that exudes into that cyst and giving it this very purpley bluish appearance. It is mostly, it can be small, it can be very large, it can be lateral, it can be present in different in more than one tooth. And the important thing is that they're not a problem. They might burst themselves with time, so you don't need to worry about these cysts, but you do need to know their diagnosis. Then we have gingival cysts of adults. These cysts are very taut. They are compressible, translucent bubble. They are mostly, they are not tinged with blood, but if they are, it means that again they are filled with blood because of some surrounding structures. They arise from cell rests of dental lamina, also known as rests of caries, and they are present within the soft tissue. They do not involve the underlying bone, but because of the pressure that these cysts create, the underlying bone may have a pressure resorption puncture, and you may see that later on after removing that cyst. This is a picture of a gingival cyst of adult. Mostly these cysts are present in the interior region. Here is a picture of histological features of this gingival cyst. We see how the epithelium has these long rete ridges. Sometimes this epithelium may have epithelial plaques on these surfaces. Sometimes they may not be present there. We may see variable inflammation. There will be no involvement of bone. And yeah. Okay, another important cyst is calcifying odontogenic cyst. Now, this cyst is a benign cyst. It is also of odontogenic origin. It is very similar to, its epithelium is very similar to ameloblastoma. And another important structure in these cysts is the ghost cells. Now, what are the ghost cells? Basically, ghost cells are altered epithelial cells that lack nucleus. And when they lack nucleus, they would appear as these pink structures under the microscope. And they are a key feature of calcifying odontogenic cyst. Often these cysts are associated with an odontoma. They are mostly present anteriorly in the jaw, and mostly they are present in the bones, and less often they are present in the peripheral areas. These cysts, under the microscope, they would show an epithelium with a palisaded basal layer. You can see the palisading over here. You can see the thickening of the epithelium, and you can see these ghost cells, these pink structures that lack nuclei. Here again, this diagram is a zoomed out picture of a ghost cell, which is a cell that lacks the nucleus. Later on in this ghost cell, calcifications occur, and because of these calcification, we name it calcifying odontogenic cyst. We also have a picture of radiograph. You can see how this cyst has these radioopicities. These radioopicities show the calcifications that we are talking about. And here you can see this cyst present in the anterior region. Here are a few etiological factors about this cyst, how it is 33% associated with the impacted tooth. It is mostly 2 to 4 centimeters in size, and it may cause displacement of the adjacent tooth. It may cause resorption of the adjacent tooth, and it may also lead to the root divergence. Okay, then we have a non-odontogenic cyst. This is an important cyst, nasopalatine duct cyst. It is, as the name suggests, it would appear along the nasopalatine suture. This nasopalatine suture is the communication between the nasal cavity and anterior maxilla in the developing fetus. Most of these cysts develop in the midline of anterior maxilla, and you can see this diagram showing this elongated pear-shaped cyst. Then we have nasolabial cysts. These are very rare, but they are also non-odontogenic, and we can see that they are present in this. They are present as a painless swelling in this nasolabial fold, and because of this, we can see flattening of the nasolabial fold, and we can see swelling of the upper lip. Then we have this aneurysmal bone cyst. It is a pseudocyst. It is not lined by any epithelium. Basically, an aneurysmal bony cyst. It consists of blood. It is a blood-filled microcyst which later on calls together to form a larger cyst. And if ever it is removed, it is going to have a lot of blood in it. They may occur spontaneously. They may occur due to a secondary infection. Other cysts that I did not include in this lecture, which are not too common and also not too important, but we need to know that there are certain cysts. There's a gingival cyst of newborn, which are very small. They are multiple. They appear as multiple keratin-filled cysts, and they are present on the edentulous arch. Then we have Epstein pearls and Bohn's nodules. These are again keratin-filled cysts, and they are present in the palatal mucosa of newborns. And we have buccal bifurcation cyst, which is present in the bifurcation of molar teeth. And we have primordial cyst, which is a cyst that develops at the site where a tooth fails to develop. Now, these cysts are important from MCQ point of view. Management. Let's just briefly discuss the management of these cysts. Cysts are managed conservatively. They can be managed in an aggressive way. There are different procedures through which they are managed. It could be decompression, it could be enucleation, it could be marsupialization, and it could be adjunctive treatments. Why is this treatment basically required? It is very important to understand that although we said that cyst is asymptomatic, but we need to understand that as they grow, they may affect the structures surrounding them. They may get secondarily infected. They may cause the jawbone to weaken and therefore leading to other problems like it may lead to a pathological fracture. And some of the cysts, they can undergo transformation and they may change and they may transform into a malignant lesion or a more aggressive lesion like a ameloblastoma, like a squamous cell carcinoma even. Now, cysts prevent eruption of teeth because they are present in the way of that eruption pathway. So it is very important to remove them. Cysts can also involve the neighboring structures as we have earlier discussed. Now, this table basically shows different options of treatment for a cyst. Conservative options include enucleation. It may include enucleation with curettage. Curettage is basically scraping of that area of the cavity. Decompression and marsupialization, we will discuss it. And we have certain aggressive treatments as well, in which we're going to talk about. Let's just talk about it, and then we will come back to this table later on. This is decompression. Now, what is decompression actually? In decompression, we basically puncture the cyst in a certain area and we place a drain inside that cyst. Now, this drain is, we are supposed to keep it patent so that the cyst keeps on draining itself. This drainage could be this drain could be placed inside the oral cavity. It could be placed inside the nasopharynx. That depends on the presence of the cyst. The diagram shows how this is a large cystic cavity, and we have a decompression tube that is placed inside the cavity. Then we have enucleation. It is the most reliable. It is the most common way to treat a cyst. We see how this cyst is present with the tooth, and then we remove the bony structure around the cyst, and very carefully we remove it with a spoon excavator with different instruments. And it is very important that we do not rupture the cyst, because if the cyst ruptures, then it means that there is a chance of recurrence. So this is a very delicate procedure, but again, very reliable, very, very important with it. And then we have marsupialization. You can remember marsupialization with marsupials. We all know marsupials like kangaroos and koalas. They have these pouches in which they keep their babies. So how do we remember marsupialization with it? Basically, in marsupialization, we remove a certain portion of the cyst. We de-roof the cyst. And we de-roof it in a way that a pouch is left behind. And this pouch is opened into the oral cavity. Now it keeps on draining itself over time. After a certain period of time, once the surgeon decides that the cyst has completely drained itself, enucleation can be done, curettage can be done, and then the whole cystic cavity can be closed down. Now, this is a diagram which shows. Okay, let's go back to this conservative and aggressive treatment. Enucleation, as we have talked, then we have enucleation followed by curettage. We have decompression and marsupialization. We can do decompression as the cyst sizes decrease. Then we we deroof it, and we do the marsupialization procedure, and we wait for the cyst to decrease in size. We And then we have enucleation and decompression. In aggressive treatments, we have enucleation and peripheral osteotomy. In peripheral osteotomy, you basically remove 2 to 3 mm of structure surrounding the cystic cavity. Enucleation with Carnoy's solution. Carnoy's solution is basically a chloroform solution which is injected into the cavity. Now, this solution degenerates the the daughter cyst, and it will help in in decreasing the size of the cyst. We have cryotherapy. This cryotherapy is done with the liquid nitrogen. That is again an important but aggressive treatment. It is often associated with carcinogens. Then, the lastly, if the cyst is if all these treatments fail, we can go with a resection. This resection would be with continuity. It could be without continuity, and we can do a dearticulation section as well. This diagram shows the presence of cysts in different areas of the mouth. We see how the eruption cyst is present with the tooth. Traumatic cyst is present near the apex because the infection occurs in these areas. We have mucus retention cyst. We did not talk about this, but this is a soft tissue cyst. We have radicular cyst, which is associated with the root of the cyst. Incisive canal cyst. We have nasolabial cyst. Residual cyst, again at the areas where extraction has taken place. And we have dentigerous cyst, which is often associated with the third molar. So at the end of this lecture, let's just summarize everything that we have talked about. Now, cyst is one of the most important pathology in the oral and maxillofacial region. They often mimic different tumors, so it is very important to check the clinical features. It is very important to go for the radiography. We cannot just diagnose with the help of just radiograph. We cannot diagnose just with the help of the clinical features. Again, cysts are benign, but some of them, like OKC, they show locally aggressive and destructive behavior. So we need to know that if it is really a aggressive lesion or if it is a cyst. History is very important in the diagnosis of a cyst. Clinical examination is very important. Biopsies, it could be incisional, it could be excisional biopsies. They are very important. And lastly, both conservative and aggressive surgical treatment modalities have been used in the past to treat them, and follow up is always important with these cysts. I hope that this lecture was helpful, and we have reached the end of the lecture, and I would like Dr. Rashid to come back. And if you guys have any questions, you can write them here, and you can always write them under the comments section later on as well. Hello. How to differentiate between radicular and denture cyst. अच्छा सर मुझे आपकी आवाज़ नहीं आ रही, but let me answer this. Okay, let's go back to the denture cyst. It's very easy to differentiate, but very important to differentiate between the dentigerous cyst and radicular cyst. Dentigerous cyst is always present with the third molar. Radicular cyst is present at the apex of the tooth. And histologically, dentigerous cyst would be mostly non-inflamed, and the radicular cyst would be mostly inflamed. So these are the few important differences. You have to go with the radiograph, you have to go with the clinical features, and you have to also see the oral examination. जी sir.